We really appreciate you guys coming and joining us today. My name is Mary Kay Battaglia. I'm the executive director at NAMI, Wisconsin. And NAMI, Wisconsin is the administrative facilitator of MHAP. So we are all here as a part of MHAP. And this is what we will be doing today. We'll welcoming you. Welcome. Thank you for being here. Then I'm going to introduce what MHAP is. We're going to do a mental health overview, and then we're going to hit various areas of the mental health system in Wisconsin: outpatient, county-based crisis, inpatient, financing, and mental health workforce. And then at the end, if there is time, we're hoping there'll be some time, we'll take questions from you guys. And who is MHAP? MHAP is the Mental Health Action Partnership. It's a broad, sustainable coalition gathered to advance equitable access and continuous improvement in integrated mental health care throughout the state. Through the work of MHAP, every person in Wisconsin will be able to easily access quality, affordable care in their community. Wisconsin will have a well-integrated, sustainable continuum of mental health services and supports that respond in a compassionate, timely, effective, and culturally informed manner for any child, youth, and adults everywhere in the states. That's a huge goal and aim of ours. And what we are a gathering of, and I'm going to use the word peers here. This is a term that we use to identify people living with a mental illness. So when you hear the term peers, that's what we're talking about. And when we talk about families, we are inclusive of all the loved ones that care for that peer. So we use those terminologies. So we are inclusive of peers, families, and advocates. We include counties, hospitals, nonprofits, adjacent things like the education and criminal justice, and healthcare systems. So I'm going to quickly highlight mental health and mental health conditions. We all have mental health. All of us have mental health. And we all have good mental health days, and we all have bad mental health days. If you're going through a divorce, you're probably having some bad mental health days. If you've lost a parent or a child or anything, you're going to have some really tough mental health days. I always say, you know, we all wake up and we have a back pain or a knee pain, and that's our physical health. We check in with that. We all have mental health, and we can all check in with our mental health and make sure we're doing well. Mental illness, when is it a mental illness? A mental illness is a time span. It's a person who is diagnosed with a mental illness. It's persistent over a long period of time. It distressing and causes significant disruption in the ability to function and work, rest, and take care of yourselves and other, and it negatively impacts the quality of your life. So this is over extended period of time, and you're not able to function as you were prior or ever. And this is where there's a difference. We all have mental health. It doesn't mean we all have a mental illness. And so we always like to differentiate those two. Also, through this presentation and as you go through life, you're going to hear the term behavioral health. This was something created 10 years ago to be inclusive of mental health and substance use disorder, because they overlap quite a lot. So the term behavioral health is inclusive of both of those things. So when you hear that, that's what it's inclusive of. So I just wanted to recognize that definition as well. So we're going to hit some numbers. 1 in 5 people live with a mental illness. Additionally, 1 in 5 people living with a mental illness have loved ones that are taking care of them, affect them. I'm a family member, and it affects me every day. I'm responding to crises. I'm taking care of somebody. I'm trying to help them out. So even though I'm not the one living with a mental illness, it also affects me. So that's why we're very inclusive of family and peers in a lot of our conversations. 1 in 20 people live with a serious mental illness. And we will define serious mental illness, and you'll see a defined SMI of people that are living with significant disability. It can sometimes be schizophrenia, untreated bipolar disorder, significant depression. That would be serious mental illness. They're just not able to really function at a high level, and so we have that specific category. So 1 in 20 people live with a serious mental illness. That would be defined in Wisconsin about 269,000 people living with a serious mental illness. As in February of 2023, 26% of adults in Wisconsin reported symptoms of anxiety and depression. Of those, 34% were did not get the needed counseling or therapy that they needed. So we see a lot of issues with people accessing mental health care and the system that we currently have. Of the 266,000 adults in Wisconsin that did not receive the needed mental health care, 37% said they didn't because of cost. 1 in 6 of our US youth age 6 to 17 experience a mental health disorder each year. 70,000 Wisconsinites age 12 to 17 say they have depression. In Wisconsin, 916 lives were lost due to suicide in 2023. So you can see this affects a lot of people. For Wisconsinites, when we say 1 in 5, that's approximately 1 million people. That's how many people in Wisconsin are affected by mental illness. And 1.5 million people in Wisconsin live in an area where they do not have enough access to mental health care. So as you can see, this is why we built our coalition. We know those numbers, we live those numbers, we hear about it every day. So what are mental illnesses that we're talking about? This graph here with the United States, it's tells you the percentage. So 19%, the highest rate. The diagnosis with the greatest impact is anxiety. Next is depression, co-occurring substance use disorder, post-traumatic stress disorder, bipolar disorder, and you can see it goes down. And these are usually your more what we call serious mental illness, the SMIs that you'll hear about. Also, this is a graph just showing the population. Mental illness does not discriminate. Some populations, some cultures have a higher rate of mental illness, and just there's the numbers just for your information. So recovery, and that is why we're here. That's why we gathered as a coalition. Is our goal is to find ways for people to find recovery and live in recovery. Unfortunately, the average delay between first onset of symptoms and getting the treatment is 11 years. That's a really long time. There's stigma involved, there's access involved, there's cost involved, there's lots of systems problems that makes a delay in people getting the care they need. For people who do receive treatment each year, 52% of adults are receiving the care that they need, but that means almost 50% of people are not receiving the care they need, right? Also in Wisconsin, we have a fabulous crisis line, 988. It's been going very well. The most significant thing that I think every month I kind of check on, there's a dashboard on the DHS website. They do a great job. And if you can see this number, which you probably can't, but it's over 6,500 calls in September of 2025. That's how many calls. They had over 2,600 texts and chats. And these are both increases, 15% from last year, 38%. Two things there. We're hoping more people know about 988, right? So the increase is there. That's fabulous. But also that's a whole lot of people reaching out who feel that they're in a crisis and need support and help. So we know it's a significant issue in Wisconsin. Our goal, though, is to catch people upstream and find ways in our system that we can get people so we can decrease that 11 years process. And also just want to emphasize that this is a lifespan. It's from infants to geriatrics. This affects people through the whole lifespan. It also affects all races, genders, incomes, and many systems in Wisconsin. So when we talk about funding, you know, we argue about how we're going to fund this and how we're going to, this would save money. But what the thing about mental health is if you invest in, let's say, peer services that we think would be helpful, we also think, you know what, it would decrease the amount of law enforcement calls. It might decrease other things. And so the whole system, you know, is intertwined. So the schools, the law enforcement, the court systems, the clinics, all the counties, because we are, you know, county-based system, and John Tuohy will discuss that, and our emergency services and everything else. So it's all in, you know, it's involved with a lot of systems in Wisconsin. So thank you so much. I am now going to hand the mic over to Kathy Markeland, and she will talk about outpatient.
Thank you, Nichole. Good morning, everyone. Thank you so much for being here.
So as Mary Kay said, my name is Kathy Markeland. I'm the Executive Director of the Wisconsin Association of Family and Children's Agencies. WAFCA is a membership organization of community-based providers around the state of Wisconsin. So our members provide a wide array across the continuum of care. We use that phrase a lot, from everything from birth to 3 all the way to residential services for adults and children. So very invested in mental health and substance use treatment delivery. Thank you so much. So across in partnership with our state and county partners and with our schools increasingly. So really a pleasure to be with you all here today. Really glad to be here with my colleagues from the Mental Health Action Partnership and the collective work that we're doing. And I'm going to move through my part pretty quickly because we wanted to do at least a dip on what outpatient care is, because I think it's the most familiar service to people. As you think about, when people think about mental health, they kind of get that picture of somebody laying on a couch in an office, right? And so that's right, the trope that we see. But when we think about this, it's really talking about outpatient mental health and substance use treatment. Again, the most familiar kind of service is this outpatient service. It generally occurs in a clinic or an office setting. And it is on a periodic basis, based on the level of need. So outpatient, obviously, just like it is with your doctor's office, right? You're not being admitted, you are coming in and out of office. So it includes talk therapy, psychotherapy, right, is the other term that we use for thinking about what that practice looks like, using evidence-based treatments with individuals to work through their questions, their challenges, their mental health issues. Telehealth is an increasingly a big piece of that. So that is a significant piece that we're watching as the growth of that piece of the system continues. We've done a lot in the state already to provide for telehealth access, for teletherapy access for people. That's going to be increasing. And so that's certainly something as we look at trends and pieces that we're monitoring going forward when we think about what it does for access. And then we'll talk a little bit more about the healthcare workforce too, but just really to kind of center when we think about an outpatient visit, who that individual is that we are working with. And those are individuals that are licensed through the Department of Safety and Professional Services, generally your marriage and family therapists, your licensed professional counselors, and your licensed clinical social workers, along with psychologists. And then psychiatrists, not so much doing the talk therapy piece on the psychiatry end, right? But really focusing in when you think about those pieces. So access, in general, outpatient is a voluntary service, although we hear a lot this morning about other court-ordered and other ways that people access treatment services. But generally, we think about outpatient as a voluntary service that is self-referred or referred through primary care. Increasingly, a best practice is integration of screens within a primary care setting to assess for depression, anxiety, and really providing for a warm handoff referral. So when we talk about integrated care, I think there can be different ways that we define that. We do think about that integration between mental health and substance use treatment, but also within that primary care setting. So integration really would pull in that physical health piece as well. And so when we think about best practice and where things are headed, wanting to provide for as much of that coordination or in a singular and a more immediate access. And when we can do that within an integrated care setting, all the better. And then higher levels of outpatient care. So I wanted to touch on that briefly within this array as well, because again, we think of that outpatient as generally sort of that one-on-one talk therapy, but certainly group therapy falls into that outpatient space as well, that we may be experiencing that in groups. We also may experience higher levels of care. So through screening and other determinations, a lot of usually prior authorization, right? So healthcare needing to approve you for certain kinds of higher level access, but other outpatient settings that you'll hear about, day treatment. We have specific day treatment for adolescents and adults separately, intensive outpatient, and partial hospitalization. So all of those are pieces that allow for more of, I would say, like an outpatient sort of approach to receiving services. I still get to be at home, but I'm getting something more intensive. And so each of those takes and represents a different level of sort of having and level of intensity of that service. When we think about like who is doing this work and where it's actually occurring, So the Department of Health Services oversees specific certifications. The two that you'll hear referenced the most are DHS 75 and 35. Shorthand, 75 is for our integrated settings. So that is and again, when I say integrated, I have to be careful, but that is for our co-occurring. So where you are receiving substance use and mental health treatment. 35 is more of a primary diagnosis of mental illness that you need to have for services in those settings. So those are specific kind of clinic settings in terms of representation across like where our practitioners actually operating. It's broader than that. You are also seeing people receive treatment through private practitioners. And I think increasingly so since we adopted capacity, is it 15 years ago? I'm gonna look at Matthew, for vendorship, we call it vendorship, but that is the ability for individual practitioners, once they are licensed through DSPS, that they can become certified part of in health insurance panels, so commercial insurance, and also through Medicaid can be independently certified to be able to provide those services. So that's an increasing piece of our service system, particularly over the past decade and a half or so, that you see more independent practices, more group practices is another term that we use, which differs from a clinic because they're not certified by DHS, but they are operating and very much look like. And so you have other settings like federally qualified health centers, health systems and hospitals that have elements of being able to do outpatient related things, but they're not necessarily under a clinic certification per se or the same certification. So we try to be careful about that. And I already talked about that piece. How am I doing? Children's continuum of care. We wanted to make sure we talked a little bit about kids here, and Mary Kay already touched on the fact that we're multi-levels of systems when you think about where people are accessing things. This is a chart that DHS did that I like the array of it. It was a representation of where Medicaid shows up across our continuum. So all the way from preventive to crisis, where Medicaid is a payer and a player in those settings for kids. What I would just emphasize about this is that, you know, there are obviously lots of other systems and pieces and payers that come into play within our Medicaid, within our children's system of care for behavioral health. And importantly, you know, we think about child welfare and child protective services and youth justice that end up being, unfortunately, a avenue through which our youth access treatment. And so it becomes a channel of that. And so I just, you know, when you think about those overlays of our systems and where people are actually receiving access, and we'll talk a little bit more about school also later, because the school-based services piece, it has increasingly become like very familiar to folks. We talk about it a lot. And so understanding really how that comes to be and what that looks like within our 400 plus school districts around the state as a service delivery site and mechanism, it varies widely. And so we're happy to talk a little bit more about that. And I think we'll have a slide at least on the funding piece about that going forward. Some current challenges and opportunities. So we just wanted to make sure we're flagging out a few of those. With regard to outpatient care specifically, expansion of integrated mental health care and substance use treatment and primary health care. So really, as I said already, expanding that integrated space is a space of opportunity and interest for improving the quality of services. I think the workforce piece, we'll talk more about workforce later, certainly, and particularly with particular competencies around co-occurring situations. So, and when we say when I say co-occurring there, not just substance use, but where we have intellectual and developmental disabilities, there's a lot of need for specialization in the mental health therapy, mental health competency space there, and increasingly with the geriatric as well population, and thinking about dementia and other co-occurring pieces there with the mental health piece. So lots of need for further specialization and competencies development. Regional access gaps, we talked about that. We'll talk more about that, but certainly we do have demographics that have challenges getting access, and then we have regional, like based on sort of parts of the state, not just rural, when you think about what the access is, but certainly rural is an important area. And then certainly thinking about the growth and efficacy of telehealth. And then healthcare coverage and financial challenges. We'll talk more about funding. Sashi will be sharing that with us, but you know, some of those barriers, high deductibles, things that people experience in the physical health side as well, but particularly present in the mental health side, because I think that people perceive it oftentimes to be a deferrable service, right? And so we defer, and as Mary Kay said, when we delay we're just exacerbating often and kind of punting that down the road in a way that's going to show up as a more acute situation. So that's my piece, passing off to Joanette. John then Joanette. I knew I was going to get that wrong.
Okay, hello, everybody. I'm John Tuohy. I'm the director of the Wisconsin County Human Services Association. All 72 counties are part of our group for working together on human service issues. And I'm going to talk about the county human service system. There we go. Okay, so how is the county human service system structured? Most counties have what is called a human service department, or it might be a health and human service department if they have public health in that. So that's the majority model. And then in county speak, we always talk about behavioral health. Mental health and substance abuse services are already, managed jointly. So 66 out of the 72 counties have a human service or health and human service department. There are 6 counties that have a separate kind of behavioral health unit. It's referred statutorily as a 5142 agency. 3 of the counties, Marathon, Lincoln, and Langley, have a partnership that they work with North Central Healthcare. Grant and Iowa County have a partnership that they work with Unified Community Services, I think their names, serving those 2 counties. And then Clark County just has 2 separate departments, of social services and 5142. Counties vary in how services are delivered. Some have their own kind of in-house clinics, clinicians. They do a lot of things in-house. Other counties, and I would say the majority of this do this, they purchase services from community service providers. And then the county is kind of the payer of the service, not necessarily the deliverer of the service. And then counties can form consortia, kind of group efforts, or have like a shared service agreement where one county buys services from another. So it really varies from county to county about how the services are delivered. So then who are the populations that the counties serve? We like to refer to it as the counties manage the public side of the behavioral health, mental health system. There's lots of private sector services. You'll hear about that as well. But as far as serving kind of that core public mental health function, that's the county's responsibility under the statutes. The people that we serve tend to be lower income, mostly if they're on the Medicaid program, people who are uninsured or their insurance doesn't cover community behavioral health types of services. People who are in justice involved, adults in the criminal justice system, or kids in the youth justice system. And you may have also served people who might be involved in more of like a civil process rather than a court process. The child welfare program where parents have a mental health need in order to participate in services as a condition of getting their kids back, or adult protective services. And then not necessarily that all the homeless population is involved in some kind of a civil action, or court action, but they might be required as a condition of their housing to participate in behavioral health services, things like that. And then just want to distinguish, the counties don't serve the entire mental health population. The state of Wisconsin is responsible for what's called the forensic population, people who have been awaiting trial but determined that they're not competent, and the state has to work with them to try to restore competency, or they have been tried, convicted, but determined not responsible because of a mental illness. So the state has the forensic population. Great. So what types of services do counties provide? Counties provide the crisis intervention, which is basically like the emergency mental health services. Call lines, we work with the 988 call line, but if law enforcement, somebody else encounters somebody that has a behavioral health need, counties are responsible for that crisis intervention services. And that includes crisis workers that go out and work with people, kind of co-responder models that some areas have where a behavioral health person goes out with a law enforcement person, things like that. Counties are also responsible for approving placements under emergency detention. So if somebody is detained because they're determined to be a danger to themselves or others, and they have to go to the Winnebago Mental Health Institute, counties are responsible for approving those placements because counties are responsible for paying for the placements. And then counties provide a lot of case management for persons in Medicaid programs. We just kind of call them the C programs. There's a whole, I'll call it a whole suite of C programs. Crisis is one, coordinated service teams, comprehensive community services, community support program, what's CRS?
Recovery services.
Yeah. Those are all Medicaid programs, and the county is the primary manager of those programs. Counties are also involved in treatment services, as Kathy mentioned, outpatient, day treatment, residential care. Again, counties aren't necessarily the provider of the service, but for the population that they serve, they are maybe the payer of that service to the community agency. And then touched on the CCS program, Comprehensive Community Services. That supports a lot of kind of community services, I'll say non-clinic types of services, things that you can do to support the people in their own home, help them function and avoid kind of deeper intervention in the mental health system. And then as touched on about hospitalizations, counties, again, as part of that emergency detention, are often involved in inpatient hospitalizations, particularly if it's done on an involuntary basis. If you go way back in history, 100 years, there were a lot of counties that operated their own hospitals. Counties have gotten out of the hospital business. But counties are the payer of last resort. If somebody needs inpatient hospitalization, they don't have Medicaid, which is limits on what Medicaid will pay for. It's called the federal IMD rule, or they don't have insurance. The counties wind up paying for that, either at a private hospital or the Winnebago Mental Health Institute. Okay, so then how do people access the county-based care? So that crisis intervention, for a lot of people, that's often the front door to get into the system, your access point. You have a crisis, counties work with you, determine that there may be a program that will help you, and you get enrolled in that. So those crisis workers are often kind of viewed as the gatekeepers to the system. As mentioned before, people may also be ordered to participate by the court because they're involved with the justice system, or their parents is under a CHIPS order or some other type of adult protective service order under Chapter 55 that the court says you have to do this. There are voluntary services if people just need help. They could reach out to the county, although resources are limited. So the extent that people can be served on a voluntary basis really depends on what those local resources are. And then there can be referrals from other programs like the Children's Long-Term Support Program that, a child might have a behavioral need and they get co-enrolled in the CCS program or some other programs. Family care is serving people with physical and cognitive disabilities, but if there's a behavioral issue, the family care agencies may work with the county and housing agencies, things like that. And then some people, probably most of the people who are served by the county behavioral health system have relatively brief interventions. That crisis, you help them out, they go on. They may only be involved for a very short period of time. Other consumers, particularly like the community support program, may be under case management with counties for many, many years if they have a persistent illness that they require kind of intensive case management. Then in terms of how does the county behavioral health system get paid for? So for a mix of behavioral or funding sources, a big piece is the county tax levy. And at the county government level, behavioral health is one of the major drivers of county budgets, along with things like child welfare services, law enforcement. So heavy impact on the property tax rate at the local level with behavioral health. Medicaid is a big payer of county behavioral health services. For some services, CCS is like this. The state pays the full amount. So the state GPR pays the non-federal share of the Medicaid benefit. Other services like crisis, a little bit of GPR in there, but not a whole lot. And CSP, those programs depend on the county match to draw down the federal funds. So it's a real mix of what's paying for which services. Counties also get community aids. That program's been around forever, 45 years or so. People kind of forget about it, but it's a big chunk of money. The only downside is it hasn't gotten increased in like 30 years. But it's very flexible money. Counties will use some of that for behavioral health services. And then there are federal mental health and substance abuse block grant awards that come to the State Department of Health Services that they pass through the counties. And then counties also, in the behavioral health in particular, there's a lot of just individual kind of grants. You're always applying for grants to do this program, that program, things like that. We're talking about behavioral health, including substance abuse services. Counties do have the opioid settlement funds. Those can only be used for substance abuse services. The person has to have a kind of opioid related need. So you can't use opioid settlement funds for pure mental health services. And then there is a process under state statute. It's called the Uniform Fee System, that if people have the ability to pay, counties can charge like a co-payment for that service. It's roughly, I want to say it's like about 160%, 170% of poverty. If like you get above that level, you might start having a copay. If you're below that level, there's no copay. In Chapter 51, covering behavioral health services, there are various spots in the statute where it says, to the extent funds are available, counties must do this. It's kind of referred to as the shield, that when the money runs out, people don't get served. And it's, I mean, that's blunt, but that's the way the system works. When the money runs out, people don't get served because counties don't have the capacity to just kick in more money. And then what you see, given that counties vary in their fiscal capacity, the heavy dependence on the tax levy funding, is there is wide variation across counties in terms of their ability to support services. Some counties have very robust behavioral health programs. Other counties have kind of leaner behavioral health programs. Okay, and then just a few challenges, and we can talk about this more at the end. As people, the other Kathy and Mary Kay mentioned, you know, there's just increasing demand for behavioral health, mental health services. People are just more aware that they need to attend to their mental health the same way that they attend to their physical health. And so people are more willing to reach out. We're making progress in kind of reducing some of the stigma and reaching out for mental health services. So people and their families are more willing to reach out than they used to be. Communities are more aware of their service needs, and that's all great, but that's like increased demand. You know, and I would say in the modern world, everybody's living in an online world that creates more stress. We're seeing that particularly for children. So it's like more demand for services, which it's good that people are reaching out for help, but the system is not growing to meet that demand. And then the reliance on the county funds as the primary supporter for that public mental health service, it makes the system kind of unstable. Counties are subject to tax levy limits, and the short answer is those work. They severely constrain counties' ability to generate revenues at the local level. So counties, it's kind of like, you know, the pocket is empty. There is no more money. in the pocket to invest in behavioral health services. So as we try to grow the system, the fact that it's dependent on a revenue source that's got no capacity for growth just means it's hard to grow this system and meet that increasing demand. And then, in Medicaid, we'll talk about this some more. There's reimbursement rates issues, whether that covers your cost. Everybody's costs are going up greatly, just a lot of for workforce reasons that you got to pay more to get the kind of skilled people that you need. And then, as I mentioned, there's this complex mix of C programs that each of them was created to meet a need, which was great. But now when you're trying to talk with people, oh, I can do this for you under CCS, I can do that for you under CSP, and I can help your kid under, this. And people are just like, what? Don't make me have to enroll in 5 programs to get all the needs that I have. So it's a very complex mix of programs. And then others will talk about this, but in Wisconsin, we're a county-based system. We're fairly unique among states around the country. Most states have a statewide mental health system or a regional system, but here it is county-based. And that reliance on the county funding is kind of like that foundational building block for the system. That's kind of a barrier. We could go to a regional system, but then what pays for the regional system? Counties will pay for their system. If we want a regional or a statewide system, we really need to rethink the whole funding structure for mental health services. So that's my spiel. Who is next?
Joanette. I just wanted Joanette to know.
Okay.
It's fun.
Yeah.
Thank you.
Sure.
Good morning. My name is Joanette Robertson. I'm the Director of the Bureau of Prevention, Treatment, and Recovery at the Department of Health Services Division of Care and Treatment Services. So what our Bureau does is oversee the state's community-based mental health and substance use services systems. So we're going to zoom out a little bit and have a statewide perspective as a state agency. Part of what we oversee are emergency mental health services. So that is our crisis services system. John, you missed a slide. So when we look at crisis as an experienced event, it's very difficult to define because it is subjective. It's dependent on unpredictable factors, and it is unique to each individual family, community, and system. Wisconsin Administrative Code DHS 34, which outlines the standards and provisions that county crisis programs need to satisfy for certification and Medicaid reimbursement, does include the following definition of crisis. Crisis means a situation caused by an individual's apparent mental disorder, which results in a high level of stress or anxiety for the individual, persons providing care for the individual, or the public, which cannot be resolved by the available coping methods of the individual or by efforts of those providing ordinary care and support for the person. That definition is intentionally very broad. It encompasses the broad and diverse nature of crisis experiences. Wisconsin Statute Chapter 51, which John mentioned, designates counties as the entity responsible for the well-being of individuals who have mental health, substance use, or developmental disabilities. Counties are required to have staff trained and available to assess for and approve emergency detentions as outlined under Wisconsin Statute 51.15. A crisis assessment and an assessment for emergency detention completed by a county authorizer needs to identify present risk and protective factors. Those factors, along with other components in the assessment, are used to help the crisis worker and the client identify less restrictive, voluntary interventions that may be available or feasible to prevent the need for involuntary treatment. Preventative and less intensive crisis interventions lead to better outcomes for clients and their families. They're more efficient, they involve less time across the system. So when we look at crisis, there's lots of people involved, including the courts, and law enforcement and the counties and public defenders. And it becomes very costly at times. So when we try to get ahead of crisis and prevent hospitalization, we have crisis services that are much less costly for counties and clients. So system challenges, we're all talking about those. And there are a few. In Wisconsin's county-based system of care, only counties can be certified under Administrative Code DHS 34 and seek Medicaid reimbursement for crisis services. Counties can and do contract for some or all of required services, but the certification always needs to be with the county. The benefit of that is that people in crisis receive a very localized response to crisis care. The challenge is, though, we have 72 different counties with 72 different crisis programs, and the response and the services that a person in crisis receives varies greatly depending on the county they happen to be in when the crisis occurs. It can lead to inconsistent and disjointed provision of care, inequity in resources for clients, challenges in collecting statewide data that can help inform policy and funding. And it's a challenge for counties who don't have access to good clinical information and civil data to make good decisions when the crisis is occurring. Additional challenges are healthcare staffing shortages that can impact services that require 24/7 staffing. An additional challenge in our system is that emergency medical services and law enforcement continue to be the first touch point for many people in crisis. Neither of those systems are specifically designed to provide the behavioral health crisis care that's needed. We depend on those systems. They're not built for behavioral health crisis care. They become very costly and inefficient, and often they lead to overly restrictive and potentially traumatizing outcomes. Lastly, there are a few crisis services that are specialized and available for some populations, including youth, people with intellectual and developmental disabilities, and people living with dementia. The Crisis Now framework is a model of care that was developed and published in 2016 by the National Action Alliance for Suicide Prevention. This model has quickly been identified as a national best practice and has been adopted by states throughout the country, including Wisconsin. The Crisis Now model promotes the idea that everyone in crisis should have access to three things: someone to talk to, someone to respond, and a safe place to get help. And it recommends specific services within each of those elements. The first component, someone to talk to, is envisioned to be achieved through 24/7 available phone, chat, and text call centers, which people can access 24 hours a day, 7 days a week. Should someone need more than a phone contact, a team of mobile crisis responders could be dispatched by the crisis call center to respond to that individual in the community in person to assess their needs and develop a plan. The last component of the Crisis Now framework are crisis response centers. For individuals in crisis who need more support, crisis facilities could be available to immediately screen and assess individuals and provide short-term facility-based stabilization with the goal of returning a client to their pre-crisis level of functioning. In January of this year, SAMHSA, the Substance Abuse and Mental Health Services Administration, released comprehensive updated national guidelines for a behavioral health coordinated system of crisis care. The three core elements of the Crisis Now model are supported in those guidelines. Additionally, SAMHSA promotes a crisis continuum of care that is embedded within a broader behavioral health system. The success of crisis intervention is largely dependent on the services and resources that crisis workers can link and refer clients to. So this includes outpatient, inpatient, and other social and human service resources beyond behavioral health, ones that serve basic needs, for example. The more accessible and available these resources are, the less likely a crisis will reoccur. So what does this look like in Wisconsin? Wisconsin has been working to model our own crisis care continuum in alignment with the Crisis Now model. Probably, I would say, for the last 10 years, we've been working on this. So you can see in this illustration with the different components of care represented in each of the 3 service levels. The yellow section is someone to talk to. This includes the crisis text line, our county crisis lines, and the 988 suicide and crisis lifeline. As Mary Kay mentioned earlier, the 988 Wisconsin Lifeline, operated by Family Services of Northeast Wisconsin, has been operating since the launch of 988 nationwide in July of 2022. It has so far answered 220,000 calls, 45,000 chats and texts, and volume continues to increase significantly. The blue section is the someone to respond section. That includes county mobile crisis response. That is available via a single person response and a teaming response, depending on the county. Co-responder models are available, like John mentioned, where law enforcement goes out with a crisis worker. And we are working currently at DHS to create a shared communication portal for minor safety plans during crisis events. This was due to legislation that was recently passed. We will be contracting with the Wisconsin Statewide Health Information Network, called WISHN, to create this portal to provide enhanced emotional support for minors by law enforcement and emergency responders in collaboration with county human service crisis programs. The green section, a safe place for help, includes Wisconsin's current youth and adult crisis stabilization facilities. These are available in numerous counties throughout the state. And this section also includes private and public hospitals. Crisis hostels will be a new type of stabilization service as a result of Wisconsin Act 249 that was enacted in 2024. Crisis hostels will add a new level to crisis stabilization to include stays that are 23 hours or less. Also under Act 249, crisis care facilities, a new facility type in Wisconsin, will be added into our continuum of stabilization and crisis care. DHS is also working on a new administrative rule and certification process for psychiatric residential treatment facilities called PRTFs for youth due to the enactment of Act 9 earlier this year. PRTFs will provide inpatient care under the direction of a physician for youth needing an intensive level of crisis care and ongoing treatment. A little bit more about crisis care facilities. As noted, Wisconsin Act 249, which was enacted last year, created crisis urgent care and observation facilities as a new facility type within Statute 51. These are being called crisis care facilities, or CCFs. Act 249 directed DHS to create emergency and permanent rules outlining a certification process for public and private entities, including hospitals, to seek certification to operate a CCF and enroll in Medicaid to be reimbursed for crisis services provided there. Crisis care facilities are intended to provide 24/7 assessment and crisis intervention services to both voluntary and involuntary persons in crisis. Persons are able to access services at a CCF outside of the county-based system, and CCFs will be able to bill Medicaid directly for crisis services externally from the county system. Yeah, that's everything. Oh, and I'm in some weird mode now. Sorry about that. Let's see, who am I handing it off to?
Can I ask a quick question?
Yes.
The crisis hospitals, how many are we looking at, and how many
CCFs, so they don't exist yet. We are in the process of writing the administrative rule. We're hoping for publication by March of the permanent rule. And then there will be a funding opportunity. The legislature has set aside $10 million to set up 1 or 2, depending on what kind of applications come in. So that's where we'll start, with the hope, hopefully being able to expand those over time through Medicaid reimbursement and other sources of payment.
And then the hospitals?
And the hostels will be an extension of current crisis services under the county. So counties can determine if they want to set up a hostel. There's currently one. That rule will probably not be fully published until maybe June of next year. But once that's in place and Medicaid reimbursement will then be in place, we expect that there will be more that will be set up.
So with all counties being separate, is there a way to combine some counties where they can work together so they don't each have their own separate?
We encourage that, but like John talked about, it's very difficult because every county really has their own policies and procedures, their own funding mechanisms, their own programs. And so we have encouraged regionalization of services. It becomes very difficult, especially on the payment end of things.
And
Can I answer questions or should we
Well,
wait?
we're gonna keep going, otherwise we won't get through all of this.
Okay,
I just want to follow up on that. And I might have missed that. How do the counties get paid or reimbursed? Is that through Medicaid?
Are we gonna talk about reimbursement? Or maybe we should wait till the end because we may cover it.
Okay.
It's the screen that's confusing us.
Yeah.
Oh, yeah,
Sorry,
Screen.
Yeah.
I didn't know the structure, sorry.
Hello, my name's Matthew Stanford. I'm General Counsel at the Wisconsin Hospital Association. We've been hosting first in the form of a quarterly meeting of Behavioral Health Task Force since I believe about 2012, and then since now 2021, we've been having a monthly WHA member mental health and addiction care forum that talks through a host of all of these issues, shares information with each other, tries to navigate which this challenging system, which I think all of us are all sharing, some of these challenges. I'm been asked to focus really on hospital care. I'll talk just briefly at the end. Our members, they really do have that full continuum. A lot of the discussions that we have at our mental health and addiction care forum are not hospital issues. A lot of them are members providing services at that outpatient, that clinic level, whether it's 35 services, whether it's 75 services, whether it's within primary care. So Kathy covered a lot of that, but I just wanted to emphasize for this group, a lot of the issues that we talk about is beyond hospital. But I'm going to focus on that first. So the hospital side of things, emergency departments and inpatient care. So I'm going to really just walk through some numbers at the bottom, and I think folks are going to probably get the slides from this. I think the source on this, so WHA Information Center has a series of about 10 different dashboards for behavioral health visits. So pulling information out of that's publicly available and free, comes from Chapter 153 data reporting that all hospitals are required to provide, which ultimately comes through the state to us. So emergency department visits. This is in 2024, looking at the number of folks that came to the emergency department with a primary diagnosis of a mental health or substance use disorder issue. 2024, that was about 78,000 individuals in Wisconsin. On the inpatient side of things, same thing, an inpatient admission with a primary diagnosis of mental health or substance use disorder. In 2024, that was almost 49,000 individuals. I'm going to focus on emergency department first and then come back to inpatient. Medicaid is a significant issue to talk about when it comes to mental health. Especially, we'll talk more about the payer side of this later. But for some perspective, 41% of all of those individuals that come to the emergency department with that primary mental health or substance use disorder issue, 41% of those patients are enrolled in Medicaid. In comparison, everybody that comes through the emergency department, the number of folks that have Medicaid there is 27%. So, and you see this, whether it's emergency department care, whether it's inpatient care, whether it's clinical care, whether it's the work counties are doing, there's a disproportionately high percentage of patients that have mental health or substance use disorder needs that are enrolled in Medicaid. And why that then becomes very important is when Medicaid reimbursement is below the cost of actually providing that care, that really has an impact on the availability and accessibility of mental health and substance use disorder services. So if 41% of your patients, we'll talk more about this on the inpatient side, but if 41% of your patients are coming through and you're getting less than the cost to deliver that care, that impacts then how do you sustain the rest of the services for everyone else as well. So it's not just a Medicaid issue ultimately, but really an overall accessibility issue. This is some data that comes from CMS that hospitals are required to provide as part of quality reporting mechanisms at the federal level. And this is a measure of how long somebody is in the emergency department if they have a mental health diagnosis as the primary reason for their visit. Wisconsin, it's good. Let's talk about some good things on this. Wisconsin scores very well on this. We are 9th best in the nation, and this is from 2023. There's some data that's almost all the way through 2024, but it's not quite there. Looking at it, actually, I think we're about 8th, but it just gets confusing when you're talking quarters versus otherwise. But so looking at 2023, and best in the Midwest, when we look at Wisconsin, Iowa, Illinois, Indiana, Michigan, Minnesota, and Missouri. And it's significantly lower than a lot of states. So, for example, we're right about 200 total minutes on that medium number. Look over, for example, at Illinois, that is about 350. You have some states that are over 400, so double the amount of time. But another way to look at this as well is there's also a measure of looking at, well, what is the time period for everybody that doesn't have a mental health or substance use disorder need? So every state, Wisconsin is not unique in this. Every state, it takes longer when you're in the emergency department due to complexity needs for folks with a mental health or substance use disorder issue compared to folks that don't. But what's then worth looking at is what's the difference? So are you in the emergency room much longer if you have a mental health issue compared to if, how long it takes to be in the ER for other patients? You look, when you're down in Florida, for example, you'll see people showing up how long the wait is in the ER. There are other states that it takes much longer. But what this is interesting is saying you take that total number of how long it is if you're a normal, a patient without a mental health issue, subtract that from if you do have a mental health issue, we look even better. We're 6th best in the nation and still best in the Midwest. So that difference in Wisconsin is about 65 minutes or so. So transitioning then from emergency department, some folks will be discharged home, some folks will be discharged to another location, whether it's a crisis or whether it's a crisis stabilization facility, peer respite, various locations where folks can go, but some also are admitted to the inpatient side of things. A lot of discussion has come up over the years of medical clearance, which is that handoff going from emergency department to inpatient. What exactly is that? So under federal requirements, there are 2 separate decisions that really have to be made before a patient is discharged from the emergency department to the inpatient. The first thing, and this is EMTALA, this is the federal EMTALA side of things. The emergency department physician, they have to use their medical judgment. This is oversimplifying it, but this is in a nutshell. Uses their medical judgment to determine if the patient is safe to be discharged from the ER. That's their obligation as the ER physician. They can't, say, nah, get out of here. I don't want to deal with you. They have to make sure that patient is safe for where they are to be discharged. But then there's the other side of the coin too. That admitting inpatient physician also has to use their medical judgment to determine if the patient is safe to be cared for at that inpatient facility, because they're going to be under the care of that admitting physician. They are ultimately responsible, and this is language straight out of the conditions of participation, CMS conditions of participation for hospitals, which is Wisconsin's hospital standard or regulation standard. That physician is responsible for the admitted patient with respect to any medical or psychiatric problem that is present on admission or develops during the hospitalization. So it's the medical clearance, and it's kind of I've been trying to avoid using the word because it's been very confusing as folks what this is and what this isn't. But the reality is it's two different decisions because you're leaving the emergency department and coming to the inpatient. Two different clinicians, two different roles, two different responsibilities. So it's an issue, it's a challenge. And by the way, this happens for all patients. This is not unique to mental health. Every single patient that comes to the emergency department, that ER physician before they discharge has to make sure they're appropriate to leave. Same thing if you're coming on to a intensive care unit, a cardiac unit, an OB unit, the same thing, that admitting inpatient physician has to, they are responsible for what happens there and making sure it's safe for them. All right, breaking it down. So of those 48,000 inpatient admissions, in Wisconsin, 42,000 of those were in private hospitals. About 2,900 in county hospitals, as John spoke earlier. We used to have a lot more county psychiatric hospitals. The way things have evolved in the state, law changes, financial responsibilities, that has changed over the years. And continuing to see decreases. The most recent example would have been Milwaukee County, which closed their psychiatric hospital, I think, 2 years ago. And then Winnebago Mental Health Institute, their total discharges was almost 2,900 in 2024. Medicaid, back to that. So 44% of those 42,000 private hospital discharges were Medicaid. On the county hospital side, slightly higher in 2024, 46%. What was reported by Winnebago was 21%. So back to that issue of when you have that many of your patients, your psychiatric units that are on Medicaid, if you're receiving less than the cost of care, that has a real impact on the sustainability of those services. Either they have to be subsidized elsewhere or you have to manage that. So as an example, in Wisconsin, for freestanding psychiatric,
a good portion of funding, and this is from 2019. We don't have later data on this, but I think it's, pretty representative of what's happening now. But private insurance does pay about a little bit over 30%, and this is for adults, 19 and older, 18 and older. And then Medicaid, as we've talked about before, is really a big portion of spending for mental health and substance use disorder. And when you add children into that, you're at about $53 billion of Medicaid spending when you're adding the whole lifespan of individuals who are getting mental health and substance use service care. The other part in blue is Medicare. So Medicare does fund some of that behavioral health care spending. And then that little purple, light purple at the top is other insurance. So TRICARE, so care for veterans, other folks. And then about 15% is out-of-pocket spending from individuals spending that money. All right, so as we've talked about, funding and financing for mental health care is very, very confusing, and it's a mix of multiple public and private funding sources. So we talked about federal funding. So we talked about Medicaid, and that is a grant that we call that increases as people lose their jobs, they get access to Medicaid, and it's not capped, right? And so, and it's also a state and federal, sorry, my notes, state and federal partnership. And so here in Wisconsin, for every dollar that the state spends on Medicaid, the federal government pays $1.54 for that. So, and it depends on the state and what your population looks like for what your federal matching assistance percentage is. That's what it's called. And so states with lower incomes and less money get like a higher federal matching assistance percentage, and that's determined each year. The other piece of federal funding that comes in are the federal grants, and I know John talked about those a little bit. So there's the Community Mental Health Services Block Grant, and I believe this fiscal year that's about 15 million that Wisconsin got. And then there's also the Substance Use Prevention and Disorder Block Grants, and those are capped. So each year you get this capped amount of money to spend, and the state kind of takes that federal funding and, like others have talked about, kind of distributes across counties and distributes across different programs. And both of those, especially the Community Mental Health Services Block Grant, that is really for individuals, children and adults with serious mental health disorders. So it's not kind of getting your preventative care piece, it's really caring for those individuals with those serious disorders. Another way that federal funding comes in, and I can talk about this, is because it comes to community health centers as well. So the members that I represent. And so 2 years ago, about 6 of our community health centers got substance use and mental health disorder grants to expand services in areas where they are located. So state funding. So obviously federal funding is coming through federal revenue, so taxes that we're paying out there. State funding is also coming through state revenue, taxes, and then also that federal matching funding that we get, especially through Medicaid, right? So that comes back to the state, and you can kind of use that money to reinvest. And so the way we see state funding coming through is in 2012, and this is more around the substance use disorder section, we saw these HOPE grants that come in, and grants were given out to states, and money was given out to counties and clinics to provide opioid disorder services. We also see funding over the last few years for like the child psychiatry consultation program. So that's also state money. Goes to, I think it's MCW in Milwaukee offers a child psychiatry consultation program, because as we talk about workforce, child psychiatry is a huge issue. We don't have a lot of psychiatrists who are specializing, and so trying to increase that access to that piece. And so right in the middle here is county funding. And I think John did a fantastic job of talking about like how that is really kind of the bedrock of a lot of the funding that is supporting individuals across the state. And Medicaid is a big part of that funding source. And then we did talk about settlement funding, and this is, you know, just more recent, right, with the opioid settlement funding. There's private out-of-pocket costs, so co-pays, private insurance, individuals just having to pay that copay even if they don't have insurance. And then for a lot of providers and clinics, and I think, you know, the hospitals can talk about it, we can talk about it, there's just things that are unfunded. And either providers take that loss, or they have private donors who help them kind of cover that loss, or they are looking for grants. So like we said, everybody's kind of looking for federal grants, state grants, or even private grants. So like an example of a private grant for community health centers is we got money from the Pew Charitable Foundation to support training our family practice providers in providing opioid use disorder services. So, you know, it's just funding comes from everywhere, but as everybody has said before, kind of that federal Medicaid funding, that county funding, and that state funding are really our biggest pieces of funding our mental health system. All right, so everybody's kind of talked about this, and this is just the service delivery system. We have the outpatient services, we have those community programs, we have schools, emergency departments. We kind of move to that next level, which is the counties and all the programs and services that they're providing, including kind of law enforcement as part of that. Then we go to the next level, which is inpatient hospital services, treatment facilities, corrections, so actually care in the prisons and jails. And then to kind of the bigger level, which is mostly federally funded, which is the state institutes for mental disease, as well as other residential facilities that are both private and state funded. But the reason I put this is here is because my next slide just shows you how confusing both the funding is and where it's going. So if you look at services and providers, we have the programs, providers, schools, corrections, institutes for mental disease. and I think we didn't talk about this a lot, but tribes. So tribes are also a really big part, and they're kind of separate from counties as well. And then we have all the funding sources. So we have federal funding, federal grants that go down to the state grants that go down to the counties, settlements. And then we have the payers, so Medicare, Medicaid, private insurance. And so that's looking at marketplace insurance as well as employer-sponsored insurance. Other federal care, so I really think about TRICARE for veterans, and then the underinsured and uninsured. So if you look at this, it's just going everywhere. And so when we talk about it, you know, you don't want the patient to know that, oh, this is coming from Medicaid, this is coming from the state, but providers, counties, individuals, the state, you have to really kind of braid all of this funding together to bring up the services for individuals. So I think I like this slide because it does show this. It's just kind of a mess. I think not at all. So an example of what this would look like, and this is on the school-based side, of how confusing the funding is and how it's moving through. So when we look at schools, we get state grant funding for schools, right? That support behavioral health services. We actually get Medicaid funded school-based services, including, so the schools can kind of get reimbursed for Medicaid for certain services, and schools have to have that administrative capacity to bill Medicaid too, and that can be an issue for some schools, especially those with smaller districts who don't kind of have that ability to do that. Federal grants supporting schools as well goes in, and then the school property tax levy actually helps fund school behavioral health care, and then also county funding, as John had said before, also is going to kind of be supporting that. And what this kind of supports is those school social workers, the nurses, psychologists and counselors. It also supports training for teachers and staff in mental health and substance use training. It can support screenings for students as well, if that's happening in schools. And then on the other side, something that's really developed over the last few years is schools are now kind of contracting with community therapists and community providers to actually either provide therapy in school, provided through telehealth, or kind of even provided for families. And what happens is the school will pay for those contracted therapists. And most often those children are covered by Medicaid. So those therapists will then either bill Medicaid to get that funded. And so another piece of money that goes in here is mental health coordinators, navigators, parent peers, and sometimes that's supported through the county. Sometimes that might be a state piece. A lot of that care coordination piece can be sometimes reimbursed by Medicaid, but is often kind of reimbursed through grants or special kind of limited money pieces. And so that's just an example of one way that kind of the financing hits a specific area of mental health care, and with schools, we just wanted to highlight that. So I feel like everybody else has talked about the barriers and things like that, so I don't need to go over that on mine, so I will hand it over to Nichole.
Thank you. So we've talked a lot about the mental health system, and we can't have a mental health system without a workforce. And so really, I'm going to be talking about the mental health workforce and the areas of concern for that. And so on here, this is a large list of different types of providers. We have psychiatrists. You know what? I should pause and tell you who I am. I'm being very aware of time. I'm Nichole Wright. I'm the Chief Clinical Officer. I'm also a licensed professional counselor by training as well. So, Journey Mental Health Center. Yes. Thank you, Sita. And so, you know, in terms of the workforce, like I was started saying, we have a lot of different providers in a lot of different areas, but they're not necessarily distributed across our continuum of care equally. And so we may have some providers that are shifting more into private practices, especially since COVID. We've had a lot of providers leave community behavioral health agencies and move into private practice, as that's an opportunity. We've talked a little bit about the opportunity of reimbursement and how they're able to make potentially a little bit more money being able to do that. We've talked about the private and public sector as it relates to the ability to be able to have those providers and to staff the hospitals, to staff all of the healthcare agencies. And, you know, I think the other piece of this is a lot of these professions have a high to debt income ratio, meaning they're spending a lot to go to school, and the return on investment isn't necessarily where it needs to be in order to pay their bills and have a living wage. So that's another area that we really need to think about. And so, you know, when that happens, if somebody's going to go and work for a behavioral health agency, they may not get, you know, necessarily a salary that's going to be able to cover their costs as a result of what Matthew was talking about before, you know, due to our reimbursement rates. If we're only paying 75 to 80 cents on the dollar at an agency, and I can speak from, you know, Journey's perspective, we're having to get donor and philanthropy dollars to be able to really cover the cost of some of those services that we're providing, because we're just not able to get the reimbursement from our payers. The other piece too is there's a lot of education that a lot of these folks on this page need to do and need to be able to provide in order to provide some of those services. And for example, in an outpatient you know, therapy agency, you have to have a master's degree in order to provide that therapy. And so that's another piece about really, if we're able to broaden the workforce and bring in peers to provide some complementary services, that might also bridge the gap to services and really be able to get those individuals in our communities into care quicker and more robustly. The next slide is really talking about the shortages, and we've talked a lot about that. Even, you know, Dane County has a bit of a shortage in our county, and so as you look at this, you're really knowing like the individuals, you know, prior to me today have really been talking about this demand for services, and this just shows you that there's continuing to be shortages of us being able to provide those services, meaning there's a lot of unmet needs that's happening across our state. And so what are some strategies? We've talked a lot about these systems of care, and we've got some ideas here. And the first one here is talking about expanding the reach of existing professionals in telehealth. We saw a huge increase in telehealth and virtual services over COVID. We've continued to see that, and that's just a really easy way for us to continue to provide those services, particularly to the areas of shortage that we mentioned before, which is quite a bit of the counties here across Wisconsin. So from that perspective, let's continue to fund, you know, make sure that telehealth is a covered benefit for all of, particularly for Medicaid. The other piece too is addressing the distribution of professionals for paid internships and loan forgiveness. That's another piece of it. A lot of the other healthcare professions have different types of loan forgiveness. And so that's another easy kind of low-hanging fruit is just add us behavioral professionals within some of those reimbursement and loan forgiveness programs, and that one, you'll increase the workforce. We're going to commit to you to working for 3 or 4 or 5 years and be able to provide those services at the same time being able to have a living wage to be able to provide for our families and live in our communities. The other piece too is retaining professionals in the workforce. So in the state of Wisconsin, you have to have 5 years of experience before you're a supervisor. And so if we have folks coming into the field and leaving during burnout or reimbursement rates, we're not going to be able to train the future of our workforce. And so that's really important and something to consider. Also continuing education. We have 30 hours that we need to put in every couple of years. And so that's another piece that we have to do. Often we're paying for it on our own too, to make sure that we're staying compliant. And so the other piece too is adding new professionals. There's been a lot of talk about peer support and really being able to make sure that that's a covered benefit. You know, we're hopeful that we'll start to have some more covered benefits for peers in the future. We have the workforce. We just really need to invest and pay them the salaries they need to be part of our workforce. And also it allows another type of service to really come alongside individuals who are struggling with mental health or substance use disorders in a very complementary way in a non-clinical setting. The other area of electronic healthcare records and AI is here, technology is here. Let's continue to make sure that behavioral health agencies and mental health agencies have the funding to really invest. It increases efficiencies, and it really helps us be able to deliver those high quality services. Another area is diverse workforce, really making sure it's easy for individuals who are maybe on that verge of retirement to continue to keep them in the field, individuals who might need childcare needs, so really being flexible with the workforce participation and really making sure that that stays. And then the other piece, which I know many of us talked about today, is the Medicaid reimbursement. We really need to make sure that we are covering more of the cost of doing business so that we can ensure that organizations can be here and provide for the services for our families and our friends. Thank you, and I'm going to pass it to Kathy.
Well, good morning, everyone. I know we're almost out of time here, but I'm Kathy Cawley. I was at Jefferson County Human Services as the director for many years. So I worked in all the mental health programs, oversaw them, developed them. And now I have a small consulting business and private practice called Ring of Life. So thank you so much for your interest and your time this morning. And there we go. What I really want to draw your attention to is our very robust and rich website there, thanks to Julia, the mental health partner at MHAP. It has all sorts of wonderful resources on. I'm just going to mention a couple that we haven't touched on yet this morning, and that's the importance of evidence-based practices. There's 3 papers on our website that talk about 3 that could be available here in Wisconsin. The Clubhouse model, there's a Medicaid benefit in 23 states for that. That's a community-based program where people can become members, they develop skills and really get assistance with employment. Another one is dialectical behavior therapy. It has lots of empirical research for treating people who have self-harm and suicide ideation. Other states have a robust Medicaid benefit for that. It's expensive to provide and reimbursement is not available for all the components of it. And lastly, but not least, is the sort of community treatment. It was developed here in Wisconsin, and it is what should be embedded in our community support programs. It has the ability to operate as a mobile inpatient unit for people with severe and persistent mental illness. So it saves law enforcement time, it saves pain and suffering for the person and their family. So those are some of the things that you'll find on our website. And then I think we want to move to questions and answers. So. And I know it's a big, robust system with lots of tentacles and lots of moving pieces. Yes.
Yeah, so one of the things that was really helpful to see is just the ball of yarn thread that's crazy. I think it's the different C-type programs and all these rules and regs. Are those mostly from the federal government level? Are those at the state level? Is there a mixture of both? And if there are things at the state level, is that something that your organization could say, hey, we could design the rules, regulations from the ground up. Here's how we simplify it. I think that'd be interesting. Okay.
So, I'll let others speak to that as well. So here's one example. There are these 15 different chapters of Wisconsin statutes and rules that are administered by these different divisions and boards. That's in Wisconsin. And all well intentioned. This is one of those areas of are we all coordinating and making sure we're not overlapping what we're doing. Every single one of those rights is well intentioned, but they're not coordinated.
Right, it's just classic, like, we built it as we go, and so now we have this big mess, and then we could rebuild this ground up.
Yep. Exactly.
Yep. Well, if you guys have ideas on how to streamline that, I think that would be very interesting.
I think that maybe I'd say the biggest piece is raising that as a priority. You know, a lot of the work that was done in the 70s and 80s was very much focused from a regulatory perspective on deinstitutionalization and correcting the harms and abuses, you know, from one flew over the cuckoo's nest, and the things that were going on in the past. And to your point, it's like now it's got to shift. And I think we've been kind of in a little bit of a no-man's land for a while. And now the focus is access. The other thing is it dramatically changes stigma. When I first started working on this 20 years ago, people didn't want to talk about mental health, trying to hide it. That's dramatically changed now. And so I think it's just, I think the most important thing right now is a paradigm shift in how we think about regulations, how we think about payment. And we start there, and it becomes a little bit easier to start trying to unwind that ball or start fresh.
And the importance of high quality care across the entire continuum. So if we had more robust community services with evidence-based practices available across the state, we may not have the reliance on inpatient beds that we do. So.
I have a question. You had the chart up in 2024 emergency. 44% were covered under 56, right? Or not covered at all. There's a
the other parts of that pie would be Medicare. Wisconsin is an aging state, so Medicare is a significant piece. The number I'm thinking more so internal ed, in my head better is from a hospital perspective, I believe it was 2023 was the first year that government payers made up more than 50% of all payment for, this is not mental health, but all care. So that's a mix of Medicare and Medicaid, and then the rest would be commercial payment, which is now, it's statewide, it's down 39%. So as Wisconsin's ages, we get older, we're seeing Medicare go up like this, commercial go down like this. Medicaid's been relatively stable, but those are the three primary sources.
And for many years, Medicare didn't pay for outpatient services. They paid you had a handful of days that would pay for inpatient, and they didn't pay for outpatient. Just recently, they've begun to pay for LPCs and more for LCSWs and more robust service arrays coming from Medicare yet too.
Yeah.
Would you say that if we are able to get kids, treatments, for their mental health, just make it more consistent that then as they get older, they require less treatment for mental health?
Absolutely.
And also other issues too, maybe, like because their mental health is better, that impacts their overall physical health too.
Absolutely. It's incredibly important. 80% of the children who have anxiety have parents who have anxiety who didn't get treatment. So the earliest possible treatment is incredibly important.
And so school-based mental health is kind of the key to bending the mental health curve over time. So if we really lean into school-based mental health, kids get the care they need when they need it, then they're more likely to be able to be treated in an outpatient voluntary situation. And then we forestall a lot of tie-in costs over time, over the lifetime.
And it probably helps parents then too, because if their kids going, then they're like, oh.
And they have to, and then the integrated care piece gets to that too, so you're seeing in your primary care, nutrition's office, kids, and you're now seeing their parents, and there's new systems where doctors can get reimbursed and, folks can get reimbursed, kind of take care of that family unit as well.
I'll add to, and I didn't have it today, a whole other sets of data, but you can look at the emergency department discharges and inpatient discharges across ages. Pandemic was funky, but you can see from 2019, there is a decline in admissions. That's a good thing. That means, the stuff that we're talking about on the front end is helping, and destigmatization. So.
And it probably helps that Medicare now covers outpatient stuff too.
And comprehensive community services became available more statewide in 2014. GPR money was added to that, so that's a fully funded benefit that counties don't have to pick up any costs on, and that serves a lot of youth in Wisconsin.
And one more thing about the workforce, as kids get care in school, the kids, are open about mental health and substance use issues. Then many of them go, oh, this is worthwhile work, and will go into the mental health profession. So I think there's a silver lining in school-based mental health care as it affects the workforce over time. All of this has got, years. Yeah.
Basically, from everyone was the account-based system seems kind of antiquated. Is there a state that's a good model if we were to,
Great question. I think there's various opinions about what a great state model would be. Does anyone else want to address that?
There have been some that have switched from a county-based system to a regional-based system that we looked at. I think Iowa was one of them that we talked a lot about. There's complexities,
Minnesota,
which we're not allowed to talk about, but others say.
Because they're the good kids.
But there are, and the part of the thing is county-based system was great, especially when we had county hospitals and the funding source was through that, right? And hospitalization was more emphasized. Now we're talking about community service, less hospitalization and more community-based services. And so the system has changed, the funding source has not changed. So we've advocated for a while, and I'm not speaking for everyone on MHAP, but I think a lot of us that are a part of MHAP have advocated for looking at regional services and you know, especially in the rural, northern parts of our state. There are examples of it up in the northern part of the state where it's 3 counties, you know, are coming together to do that. It's just a lot of people have to agree to play, and I think it's at a complicated shift. But there are states that have gone from a county-based system to a regional-based system that we could look at.
Colorado, Missouri are some examples that have been held up. But comprehensive community services are required to be regionalized, and actually there's a higher reimbursement for emergency mental health services for regionalizing too. So just some things to think about. But remember, there is no other healthcare issue that is paid for by property tax, right? So if we're going to change this, we need a lot more state money, in my opinion. So.
Hi, Brian Battaglia, intern at Stanford from the Francesca Holmes office, and we happen to have a presentation yesterday from a group called Wisdom, which does justice reform around the state. And one of the things that came up in that presentation yesterday was, I think they said like 40%, upwards of 40% of incarcerated folks have mental health issues. And I'm wondering, you know, what you folks are doing to, or if you're collaborating with, you know, criminal justice reform stuff and where that's at, because obviously that's a, you know, not good outcomes for anyone in that situation.
Yeah, we have work groups within MHAP, and one of the work groups is the criminal justice work group. And I co-chair with a law enforcement officer from Waukesha County, but we also have court counsels, we have clients and family members, we have judges, we have police officers, you know, people coming together. We have people who work in the prison system. We have people coming together to lean in and go, how can we fix this? And right now we're focused on the emergency detention, chapter 5115. We think that this is something where we can catalyze change if we can fix this.
And Nick, I have all numbers, but I would say a lot of us are supporting the recent legislation that's come out that's bipartisan on the 90-day pre-release.
Yeah.
For individuals, so that's something that our members talk about as well.
But that's a perfect example of upstream, why, you know, over and over and over again, we keep hearing the largest mental health institute are the jails, right, our prisons, right? We have way too many people with mental illness in our jails and prisons because they took about 11 years to get care that I talked about earlier, and we need to catch them earlier. So people that are in a psychotic state can have behaviors that are not seen normal. Cops are called, they come, they somehow end up in our jails and prisons and not getting the care they need. We see it happen over and over and over and over again. That is a huge area that we need to, all of us need to spend more time on because we're not helping those folks.
I think that doesn't fit in the proposal about treatment alternatives and ever expansion. We submitted a sign-on letter to as testimony to that recently, and then we also have a proposal. So both these proposals you can find on the current policy page on our website. So we've got one about PHAP expansion and what about all those in the department.
Which TOC submitted in the budget, but it was stripped out in the current budget.
Please, we have your thingy, we have information resources, links to our website, lots of information, lots of our policies that we proposed and will continue to work on. And I didn't say this in the beginning, Kathy, and I was supposed to say, we're all invited here as experts in a specific area. We come together as MHAP, but please reach out to us as a group or contact MHAP that's on that sheet, and Julia will direct you to the person that's the expert in that area. And we just want to be able to source the channel the information and knowledge to you guys as best we can.
Well, thank you very much. Thank you for your interest and your time.